So what is the at-risk population? Well, patients who have known to have diabetes with one additional risk factor, commonly patients above the age of 50 with a history of smoking or diabetes, and then also patients who are older again or who present with leg symptomatology or abnormal lower limb pulse examination. For this part of the lecture, I'm going to concentrate on how diabetes affects our patients. So what is diabetes? Well, we all know that diabetes is, my feelings, it's basically pandemic. It's defined as a disease in which the body just doesn't produce or respond to the hormone insulin, and that leads to abnormal glucose homeostasis with elevated glucose levels within the blood that can lead to a number of factors. When we look at the World Health Organization definition, diabetes is described as a metabolic disorder of multiple etiologies, characterized by chronic hyperglycemia with disturbances of carbohydrate, fat, and protein metabolism resulting from defects in insulin secretion, insulin action, or a combination of both. This can lead to long-term damage, dysfunction, and failure of multiple organs. Again, insulin-dependent and non-insulin-dependent diabetic terminology has been replaced by type 1 and type 2. I'll pause for a few seconds on this slide. This slide is horrifying. Every part of this slide suggests that diabetes is going to increase dramatically in prevalence, particularly amongst our children. It's very high incidence and prevalence in the Western world, and it's an increase that we're seeing that's nearly exponential in the last 20 to 25 years, and indeed this is based both in the United States and also the United Kingdom. Here we can see projections for 2030, and actually if we look at the population, which is between 7 and 9 billion, nearly 500 million people will have diabetes at 2030. So how is diabetes and peripheral arterial disease, how are they linked? Well, for me, they're two parts of the unholy triad if you add renal failure into this algorithm. A lot of diabetics have peripheral arterial disease at 10 years following diagnosis, and that's very particular if you're a young patient diagnosed with diabetes, and this becomes nearly 50% at 20 years. It's also important to realise the inverse relationship, where 20% of patients with peripheral arterial disease have diabetes. Diabetic patients often have infrageniculate, which is disease affecting the runoff vessels below the knee, and peripheral arterial disease is a lot more aggressive, it's more difficult to treat, has a higher risk of lower limb amputations, and diabetic ulcers are simply a nightmare to treat and to maintain full healing without amputation. So one of the key things for me is, why does diabetes lead to vascular pathology? And I'll pause this slide just to allow you to think about potential answers. So this pause break will be, why does diabetes lead to vascular pathology, with a picture of Inspector Clouseau. I'll pause again. So why does diabetes lead to vascular pathology? Well, a diabetic vasculopathy does appear to be related to disorders in vascular homeostasis caused by hyperglycemia. This then affects the endothelial and smooth muscle cells, which leads to pro-inflammatory and thrombotic effects. This affects both the macro and the microvascular systems, and this prolonged hyperglycemic course is exacerbated by high blood pressure, high cholesterol, as well as an overall genetic susceptibility. Unfortunately, these detrimental effects of glucose really occur very early, and it's unclear whether a high level of glucose that we identify in blood sugar monitoring is related, or whether this happens at sub-threshold limits and therefore indicates that disease occurs at a very early stage. So it occurs early, it's related to hyperglycemia, and this leads to endothelial and smooth muscle cell dysfunction. On this slide we can see that when you have a high glucose concentration, it alters vascular function and then affects nitric oxide, which is really a vasodilator type agent within the body. And then you also have an accumulation of reactive oxygen species or free radicals, which then cause damage to the endothelial layer. These free radicals or superoxide ions then create more effects, and then the whole process seems to trigger further deterioration. So what are the current advances in pathophysiological mechanisms? Why do I have this slide? Well, one of the issues is if we knew what caused vascular disease in diabetic patients, then would it sound appropriate that we would instigate a treatment factor for that parameter, and therefore we could limit the damage that diabetes causes to our patients and their lower extremity arterial system. But we don't have that at the moment. Hyperglycemia and insulin resistance are key players. They affect the endothelial layer, and this can have a major role in precipitating diabetic vascular disease. Current concepts are looking at endothelial-related factors, particularly in obesity-induced insulin resistance, which I believe is going to be a huge factor for clinicians over the next 10, 20 years and further on. Whether or not this causes actually damage to the RNA and DNA and the inability of blood vessels to repair themselves as we age continually. Whether or not it causes a prothrombotic state due to effects in coagulation or platelets, and whether or not the reactive oxygen species themselves are disastrous to the arteries themselves. So when we talk about global clinical evaluation, we really want to just look after the patient in totality. It's not just their big toe, it's not just their kidneys, it's not just their eyes, it's the whole package that we need to be aware of. And to do that, we need to be very aware of patients' blood supply and their septic load. So my paradigm for treatment for all diabetic foot disease patients, whether they come to me with a small ulcer or whether they come to me, such as in this case, with a fulminant diabetic foot abscess, which can be disastrous, is that I want to know about their blood supply. Is it sufficient to facilitate healing, whilst also simultaneously trying to reduce septic load, which often warrants drainage of abscesses or even amputation of gangrenous digits or even major limbs.